Welcome to an introduction on Evaluation and Management, or E&M codes. Today's session will provide you with information regarding evaluation and management codes so that you will have a thorough understanding of the codes that are used to report the visits with your patients. My name is Stacy Olson, and I'm a certified professional coder with a specialty credential in evaluation and management services through the American Academy of Professional Coders. CPT is the code set that is used to report professional medical services, and evaluation and management codes are a small portion of the CPT code set. CPT codes are developed, maintained, and copyrighted by the American Medical Association. Every attempt has been made to provide you with accurate and current information, but the coding rules can and do change, and it is always the provider's responsibility to know what the state and federal rules are and to remain current on payer policies. Today's information is not legal advice or a reflection of any individual health system's policies or procedures. It is not instructing providers in the services they may perform and/or bill. It is meant to inform you of general knowledge and best practices for billing and documenting medical services. Our objectives in this session will be to identify the evaluation and management codes and how they are to be used. We are going to distinguish between new and established patient codes and identify the billing and documentation requirements for consultation codes. We will also list other services that are contained in the E&M section of CPT that pharmacists may be performing. Evaluation and management services are also known as E/M or E&M, so you will see these abbreviations throughout today's session. The E&M codes may also be referred to as level of service or LOS. All of these terms are synonymous with each other. As I stated earlier, these are the CPT codes that will report your face-to-face visits with your patients. For every E&M code, CPT requires that a certain level of history, exam, and medical decision-making be met for reporting the E&M code. There is also a typical time assigned to each E&M code, and there are other recorded sessions to educate you in each of these areas. Today's session will be a general overview of what E&M codes are so that you understand the codes in full. CPT has general guidance about how providers can obtain the levels of history, exam, and medical decision-making that the E&M codes require. But CMS, which stands for Centers of Medicare and Medicaid, has provided more specific guidance on how to reach the levels of history, exam, and medical decision-making in their 1995 and 1997 documentation guidelines. E&M coding is a combination of what CPT and CMS have provided as guidance. The reason that the CMS guidelines matter for E&M services is because commercial payers generally follow CMS guidance in addition to CPT. CMS states that qualifying providers for billing E&M services are physicians and the non-physician practitioners listed on this slide. CMS does not recognize pharmacists as a non-physician practitioner at this time, but views them as auxiliary staff, which means that pharmacists cannot be credentialed with Medicare or Medicaid. Because of this, any services that a pharmacist renders to patients who have Medicare or Medicaid as a payer must be furnished under the Incident to rule, which is discussed in another online session. Essentially, it means that pharmacists are limited in the levels of E&M services that they can perform, and that the service must be billed under a supervising physician or other CMS-recognized non-physician practitioner. CPT states that a qualified healthcare professional is an individual who is qualified by education, training, licensure, regulation, and facility privileging when applicable, who can perform a professional service within their scope of practice and independently reports that professional service. So this is where SB 5557 has made a big change for pharmacists. SB 5557 requires all commercial large group, small group, individual, and family plans to add pharmacists to their payer-preferred networks, and that pharmacists can now be credentialed with payers and bill under their own name and payer-specific ID numbers. SB 5557 requirements for pharmacist coverage also does not apply to any other federal-funded plans such as TRICARE, state plans, Taft-Hartley plans, or commercial self-insured plans. Pharmacists differ from other non-physician practitioners slightly because they cannot diagnose medical conditions or injuries, but they can provide and bill some of the same CPT codes as allowed by their Washington state scope of practice. For the insurance plans specified in SB 5557, they are not considered to be auxiliary or clinical staff, which CPT defines as someone who works under the supervision of a physician or other qualified healthcare professional and who is allowed by law, regulation, and facility policy to perform or assist in the performance of a specific professional service, but cannot individually report a professional service such as a medical assistant or a registered nurse. Payers generally will reimburse physicians and non-physician practitioners differently. They generally will allow 100% of their fee schedule for an E&M code performed by a physician and 85% of their fee schedule for a non-physician practitioner. Premera Blue Cross is one payer that has issued specific guidance that pharmacists will be treated the same as an ARNP or a PA in their network. CPT divides the E&M codes into broad categories, such as office visits, hospital visits, consultations, and more. Each category is further divided into 2 or more subcategories of E&M codes. For example, the office visits are divided into new patient and established patient visits. The hospital codes are divided into subcategories for initial care and subsequent care. Each category or subcategory is further classified into levels of E&M services identified by a code that consists of 5 numbers. This classification is important because the nature of work varies by the type of service, place of service, and the patient status. E&M codes are not interchangeable among different categories or subcategories. In other words, a Level 3 established patient will require different component criteria to meet the code than a Level 3 new patient visit. Each category and subcategory of E&M code will contain 3 to 5 levels, and CPT states that each level of E&M may be submitted by a physician or other qualified healthcare provider. Pharmacists now qualify as other qualified healthcare providers as outlined for the payers identified in SB 5557 in the state of Washington. Per CPT, evaluation and management services are professional services that require direct face-to-face contact with the patient and/or family. CPT defines a new patient as someone who has not been seen by that provider or a provider of the exact same specialty or subspecialty within the same group practice for the last 3 years. New patient E&M codes extend across all outpatient settings the patient may be seen in. For example, if the patient is seen in the office by a provider, and within 3 years that same patient is seen in their home by another provider of the same group, the home visit would need to be reported with an established E&M code. Established patients are patients who have been seen in the last 3 years by that provider or a provider of the exact same specialty or subspecialty who belongs to the same group practice. Per CPT, qualified healthcare professionals, such as ARNPs or PAs, who are working with a physician, are considered as working in the exact same specialty or subspecialty of the physician they are working with. Under SB 5557, this should also be true for pharmacists with the insurance plan specified. CMS states that face-to-face contact with the patient establishes the patient, and even if a provider transfers to a new organization, the patient should not be billed as a new patient, although technically it's not under the same tax ID or group practice. I recommend that pharmacists check with individual payers to see how they will be viewed in the payer network. Providers who are on call to cover for another provider's schedule are treated as if they are the regular provider and should code new versus established patients based on the same principles as the provider that they are covering for. Consultations are a type of E&M service. They occur when a provider or other appropriate source requests the expertise or opinion from a provider that possesses skills or knowledge they do not have. The consulting provider may determine whether to accept responsibility for the ongoing management of the patient's entire care or for the care of a specific condition or problem. There are 3 requirements that must be met and documented to bill a consultation. These requirements are often referred to as the 3 R's. The 3 R's stand for request, render, and report. A request must be made by a provider for an opinion or recommendation regarding the patient's care. The consulting provider must render and document the service, and the consulting provider must also send a separate written report of their findings back to the requesting provider. The request for the consult can be written or verbal, but it must be clearly stated in the medical record. I recommend that the consulting provider documents that request on the first line of their progress note. For example, they might state, "I was asked to see this patient in consultation by Dr. Blank for XYZ condition." This makes it clear to anyone reviewing the note at a later time that there was a request for consultation. The request must come from a valid source. Valid sources would be other medical providers, insurance companies, or an other third party. However, if a family member or friend of the patient sends them to that provider, it is not a consultation, even if the family member or friend happens to be a medical provider. I recommend staying away from using the term referring provider if you are performing a consultation, as this can imply a transfer of care for the problem versus an actual consult. The diagnosis may be known or unknown, and the consulting provider may initiate diagnostic testing or treatment at the time of the consultation. Essentially, a consult determines whether that provider will remain involved in the care of the patient's condition. The final requirement is getting a report of findings and/or opinion back to the provider who requested the consultation. CPT does not specify what written communication should be. Some organizations require a separate letter to be sent to the requesting provider, and other organizations will allow the consulting provider to CC or forward their progress note to the requesting provider. Regardless of the method used to communicate the findings, it should be a thorough accounting of any diagnostic studies ordered and/or reviewed, as well as the treatment recommendations for the patient. In 2010, Medicare stopped paying for consultation CPT codes, which I'll show you a little later in this session. No one is really sure why they decided to stop paying for these consultation codes, but since that time, many other commercial payers have followed suit and do not cover consultation codes either. In Washington State, the 2 largest commercial payers, which are Regence and Premera, do not cover the consultation codes, and there are other payers that do not as well. You will want to check with the payer to find out if they are still accepting these codes or not. When Medicare stopped paying consultation codes, they stated that providers who are seeing a patient to perform a consult should still document the service with all of the previous requirements that I discussed on the previous 2 slides. However, the guidance issued by Medicare for coding purposes at that time was to bill with the appropriate E&M codes for the setting that the patient was seen in, and commercial payers who no longer have those consultation codes in their fee schedules have followed Medicare's guidance. In the inpatient setting, a consultation should be reported with an initial hospital care code, and if seeing the patient in the office or other outpatient setting, that patient's visit would be billed either as a new or an established E&M code based on whether the patient had been seen in the last 3 years. Some other terms that are relevant to E&M coding are transfer of care and concurrent care. Transfers of care are billed as new or established patient visits. This means that the patient is being sent to a provider for a certain condition, and the referring provider is essentially relinquishing responsibility for caring for that patient's problem. They may remain up to date on the patient's condition, but the other provider is going to be treating that condition. For instance, if a primary care doctor sends a patient to a neurologist for Parkinson's disease, they are usually asking the neurologist to treat the Parkinson's disease, which would be a transfer of care. Concurrent care is the provision of a similar service to a patient on the same day by more than one provider. For more than one E&M code to be paid on the same day, the providers must have different specialties and see the patient for different reasons. If a pharmacist and a physician working in the same group practice see the patient on the same day, only one E&M code can be billed, and usually it will bill under the physician as a higher reimbursement can be obtained. CPT states that there are 7 components of E&M, and 6 of them are used in determining the level of service. The 3 components on the left, history, exam, and medical decision-making, are the key components in selecting an E&M service. The 3 components in the middle, counseling, coordination of care, and the nature of the presenting problem, are considered to be contributing factors in the majority of encounters, but counseling and/or coordination of care may not be provided in all E&M encounters. On the right, we see time, and time is used as the controlling factor for selecting an E&M service when the encounter is dominated by counseling and/or coordination of care. There is a separate CE session for time-based coding, so please be sure to review that session to fully understand what the requirements are for billing using time and the documentation needed to support it. CPT defines the nature of the presenting problem as the disease, condition, sign, symptom, or complaint that the patient presents with. They define 5 levels of presenting problems, and this should be the factor that drives the level of the other components performed during the encounter for the patient. Minimal is a problem that may not require the presence of a physician or other qualified healthcare professional. However, the service is provided under the physician's or qualified healthcare professional supervision. These problems are often reported with the lowest level of established E&M code, which is CPT 99211. Self-limited or minor is a problem that runs a definite course, is transient in nature, and not likely to have any permanent effects on the patient's health status, or it has a good prognosis with treatment. Low is a problem that has little or no risk of morbidity or mortality, and a full recovery is expected. Moderate is a problem that has moderate risk of morbidity or mortality without any treatment, or there is an uncertain prognosis and an increased risk of prolonged impairment. High is defined as a problem where there is an extreme risk of morbidity or mortality without any treatment, or a high probability of severe prolonged impairment or risk to life. To select the E&M code for billing purposes, we must first determine the most appropriate code category or subcategory to select the E&M code from. This will be decided on where the face-to-face service was rendered to the patient. Next, we should determine if the patient is new or established, or if the service is more appropriately classified as a consultation for the payers who will still accept the consultation codes. We also need to decide if the E&M should be coded using time as the controlling factor, or if we should use the 3 key components of history, exam, and medical decision-making for complexity-based coding. We need to know our payer policies and we must follow all of the coding guidelines in CPT for the E&M code we want to report. I want to introduce you to some of the E&M codes for the settings that the WSPA anticipates pharmacists may be seeing patients in. Many of you may not have had any previous exposure to CPT codes, let alone the E&M codes. When you see PF on these tables, that will represent problem-focused, and SF will mean straightforward. This slide represents the category for outpatient ambulatory or office settings. In the table at the top, we see that there are codes for new patient visits, and the bottom table, we have codes available for established patient visits. These tables show the CPT code criteria for both complexity-based coding and time-based coding. Note that the new patient codes require all three components, the history, exam, and medical decision-making, to meet the levels listed in the table in order to be reported. Established patient codes require two of these three key components per CPT. I have also listed the typical time associated with each level of E&M code. This typical time will only be used for coding purposes when the majority of the time is spent in counseling and/or coordination of care. Otherwise, time does not play a role in assigning the E&M code. This slide represents the category of codes for evaluation and management services rendered to a patient in a domiciliary, rest home, or assisted living setting. These are facilities that provide room and board and other personal assistance services on a long-term basis, but do not provide a medical component of care at the facility. These codes are also categorized into new and established patient visits and follow the same concepts of needing 3 out of 3 components to be met for new patient visits and 2 out of 3 components to be met for the established patients. However, we can see the third level of new patient visit in this setting requires moderate medical decision-making, whereas the third level of new patient visit in the office or outpatient setting requires low medical decision-making. The typical total times associated with each level of new and established E&M in this setting are also different than they were in the outpatient or office setting. If we look at the medical decision-making for CPT 99337, it says that you can have moderate or high MDM. It is important for you to understand what is required for each of these code components. Here we have the E&M codes for visits that are provided to the patient in the patient's own home. Again, these codes are categorized by new and established patients and require the same component criteria to be met for each subcategory of codes as the office or assisted living codes. If we compare this slide to the previous slide, we see that the codes are different, but the key components and typical times assigned to the home codes are a mirror image of the key components and typical times assigned for the domiciliary, rest home, or assisted living center codes. This slide represents evaluation and management services that are rendered to a patient who is classified as an inpatient hospital status. In the inpatient setting, new versus established concepts do not apply. Rather, we see the codes listed as initial care and subsequent care, and each of these categories contains a total of 3 codes to choose from. Initial care is billed the first time you or someone from your group practice sees the patient during an admission, and the subsequent care codes would be reported for each day that the patient is seen during the admission following initial care. When we look at CPT 99221, which is the lowest level of initial hospital care, it allows for either a detailed or comprehensive history, a detailed or comprehensive exam, and the medical decision-making can either be straightforward or low. There are also codes that report the discharge, but the provider or group listed as the attending for the admission must be the one to discharge the patient. If a provider from another service sees the patient on the same day that the patient is discharged, that provider would report a code from the subsequent visit codes. In looking at the code descriptions in CPT for subsequent codes, there are notes listed under each of these codes that guides us in which code to report based on the status of the patient's problems. 99231 states that the patient is stable, recovering, or improving. 99232 states that the patient is responding inadequately to therapy or has developed a minor complication. And 99233 states the patient has developed a significant complication or has developed a new problem. These are the codes that are used for patients who are seen in nursing facilities. These facilities provide a long-term care environment and also provide a nursing or medical component of care at the facility. Again, we see initial visits, which will require 3 out of the 3 components to be met, and subsequent visits, which require 2 of the 3 components to be met. However, there is a difference in the level of history, exam, and medical decision-making, and also different typical times than we saw on the slide for the inpatient hospital codes. It is very important that you don't assume that from setting to setting, the components and typical times are the same for the levels of service. This slide lists the codes to report outpatient consultations in the first column, and inpatient consultation codes are in the second column. The levels of history, exam, and medical decision-making are the same for each level of consultation in either setting, but the typical times associated are different from setting to setting. Consultation codes require all 3 components to be met or exceeded to report the consult code. These are the other E&M services that the WSPA has identified as potentially being a service that pharmacists may be involved in performing or billing. There are different codes for each of these categories in CPT, and each will have its own specific guidelines and code criteria in order to report the code. We don't have time to get into each of these evaluation and management categories today, but I wanted you to know about them so you can start exploring other care opportunities for your organization. Here are my sources for this session. I recommend you read them for yourselves for a thorough understanding of the guidelines. If you work for a healthcare organization and have a coding educator available to meet with you, I would encourage you to do so to understand the organization's policies and procedures regarding E&M coding. Thank you for listening to the introduction on evaluation and management services. I hope that it has helped you to understand what E&M codes are and how they will be used in your organization and daily lives.